Wonderful. Well, it's really an honor and a pleasure to join you today, and I'm very sorry that I'm not there with you, and very much appreciate you making accommodations for my remote participation. And I almost feel like I should just start by saying ditto, because I think you've already heard several of the remarks that I would be sharing with the colleagues that are on the panel, and so I'm hoping that this is certainly resonating as we move forward. So I just wanted to begin by acknowledging that the work that I'll share with you is really only possible thanks to the savvy of several founding members of the County Health Rankings and Roadmaps, and the strategery of our current colleagues in Wisconsin and across the nation, including a collaboration with the Robert Wood Johnson Foundation. So let me just briefly offer a bit about County Health Rankings and Roadmaps. Since 2010, County Health Rankings and Roadmaps has been providing local communities across the nation with a snapshot of health and working to support their efforts to move with data to action. Our goals are really to build awareness of the multiple factors that influence health, to provide reliable, sustainable sources of local data, to engage and activate local leaders from many sectors, and to connect and build power among community leaders that are working to improve health. And to be clear on why we come to work, our purpose is twofold. The first is to improve health outcomes for all, and this includes both how long people live and how healthy they are. And the second goal is to increase health equity by creating community conditions that can close the health gaps between those with the most and least opportunities for good health. And our work with County Health Rankings and Roadmaps is truly in service to local change makers and in support of community efforts to bring people together to look at the many factors that influence health, to select strategies that can improve health for all and close gaps, and to make changes that will have lasting impact. And we do this by providing data such as the County Health Rankings, evidence, as in our What Works for Health, and guidance such as our as our Action Center. And we also work together and share stories of communities that can serve as examples and inspiration for improving health and equity. So let me just offer a brief overview of the ways that County Health Rankings curates data with an overarching framework that can support local change making, and I can speak to other aspects as needed. So this County Health Rankings model helps to guide our work as it really illustrates how we think about what shapes health in a community and what we measure in the County Health Rankings. As you can see, this model calls attention to the importance of policies and programs and systems change in improving the variety of factors that in turn can shape the health of communities. The overall rankings are based on a composite measure of length and quality of life, and this is really a summary measure of several underlying, including premature death, self-rated health, mentally healthy days, physically healthy days, and low birth weight. And the annual release of the rankings is really intended to call attention to the action that's needed to improve the opportunities for everyone's good health, both for the residents who happen to be in the least healthy counties and also for those who don't have a fair chance at achieving good health in the counties that rank among the healthiest. The County Health Rankings team draws upon the most reliable and valid measures that are available to compile the rankings. We don't collect original data ourselves. Rather, we use the data that others have collected from more than 20 sources, such as the National Center for Health Statistics, the American Community Survey, or the Comprehensive Housing Affordability Strategy. And we seek to provide the most recently available data and pursue sources that are publicly available and transparent in their methodologies. And in total, we offer a snapshot to nearly all 3,140 and some counties, comprised of 35 ranked measures, in addition to 37 plus additional measures, depending upon which state you're in, that can offer context. And we prioritize measures that are valid and reliable and that have been tested and used by others. So as you heard Tom describe with regard to America's Health Rankings, we also have a set of criteria that help to guide the measures that we include in our data set, and it seems that these are perhaps comparable to the criteria and considerations for the Healthy People 2030 and relevant maybe to the selection of leading indicators. Our criteria generally fall into two categories. Those here represent our program goals and community needs category. And regarding the selection of these measures, we are abiding by criteria that state that our measures should reflect important aspects of population health that can be improved. In other words, modifiable factors. The rankings are about data and communication, so it's important that each measure and its association to health can be effectively communicated to the media, to communities, and to other key audiences. We try to use our measures to speak to current or emerging health issues of importance and their root causes that will bring new and influential stakeholders to the table. We replace measures if we find ones that are more closely aligned with or can provide better estimates of the underlying constructs that we are trying to measure and communicate about. And we try to uphold alignment with other metric initiatives such as America's Health Rankings or City Health Dashboard. And last but certainly not least, we look for measures that will advance our efforts to support local change making on upstream drivers and community conditions that can shape health equity. We also have several criteria pertaining to the technical or analytical feasibility. For example, perhaps obviously we use data that are available at the county level. And as I mentioned, we don't collect data ourselves. Instead, we look to the data sources for measures that are valid and reliable and have been tested and used by others. We try to provide data that are applicable to as many counties as possible, so we prioritize measures with good coverage over a large number of counties. We use the most current data available prior to our release and seek sources that are regularly collected and publicly available. And finally, each measure in our ranked data set must be rankable. And by that I mean that there must be a clear best and worst value. So we've seen communities take action using this data from the rankings and other sources in a number of ways, including to assess the health of the community. We find that the county health rankings are one of the most commonly used sources for community health needs assessments. We've also seen rankings data used as a tool for engaging communities in health improvement conversations and action to help identify root causes, to support decision-making and policy change, and to track progress. So I'll offer a few comments on the critiques and cautions of the rankings framework and data. As I'm sure it goes without saying, data platforms have different purposes, and we've found that it's important to be able to articulate the strengths and limitations of our tools and their utility to local change making. Our data sets were built to provide communities with the best available data on select drivers of population health, and by extension with what works for health, evidence-informed strategies that can improve health, and also as a way of sharing our underlying theory of health that can broaden the definition beyond the traditional healthcare frame. Our data sets provide a wonderful compilation that highlight what research tells us is important to health in a highly digestible format, and offer high-level resources for local communities to track their own progress in a select subset of drivers and outcomes. But in the case of the rankings data set, there are a range of limitations for effectively addressing research questions, and we've certainly recognized there are other limitations. So for example, measures in the rankings data set represent the best available data, but there's a time lag that varies by data source. Some of the rankings measures serve as proxies for a particular health factor. I know you heard Tom describe this as well, but drug overdose deaths approximate drug use in a county in our data set. And in the interest of generating reliable data for community types with small and large populations, we combine multiple years of data, but this can mask change over time. And the methods and measure definitions that data stewards use to generate output for county level measures or modeled estimates that may be used can vary. And in some cases, it's not favorable for exploring trends. So while the rankings model has increasingly grown in recognition and for its ability to illustrate what shapes health, there have been valid critiques, such as those of Krieger and Arndt. And of course, Tom already called this out, but it wasn't actually Pat Remington. Rather, it was another one of our former University of Wisconsin professors, Dr. George Box, who said all models are wrong, but some are useful. So I'd offer that these are critiques and cautions with the rankings model, and to say that it doesn't serve all purposes. One valid critique is that the rankings model describes drivers of population health, but clearly doesn't really call attention to the drivers of equity. Another overarching critique is that there are many factors that influence health beyond those that are articulated in our model. And as Tom mentioned in America's Health Rankings, the model can be a simplification to some to 100%, but really for the purposes of calculating ranks. The rankings model and the percentages that are applied to the 4 categories of the health factors provide a way to summarize health outcomes and modifiable factors, and as I said, guides how we calculate the ranks. The rankings also don't include other important factors that influence individual health, like genetics and biology, but those are not feasibly changeable at the population level. So I would imagine that selecting parsimonious set of measures for Healthy People 2030, some of these same critiques may emerge. Worth noting in summary, I guess, just to recognize that data are only as meaningful as the actions they inspire, and the County Health Rankings and Roadmaps program has been committed to moving beyond defining the problem statement with the rankings and to supporting solutions and action, as I know is the case with Healthy People 2030. So in addition to the rankings data, we strive to provide communities with a range of resources, like I mentioned previously with What Works for Health as one example. So I would just offer a few considerations that represent, for us anyway, data and metric-related questions that we continue to ask of ourselves, and that may be of relevance to Healthy People 2030. To some extent, these may seem basic or even abstract, but represent areas of continued inquiry for us. The first is relating to indicator selection, and the question being whether leading indicators should be scaled or scalable by geography, and if so, how low do we go? There are both technical and practical considerations as we begin to zoom in and out, and from our perspective, with the county unit being the common unit of geography, but with sub-county geographic units such as census blocks, and even as it turns out, counties can change boundaries over time. And further, subunits like zip codes don't always scale neatly to the county or state borders, which can make it difficult to relate to a larger, meaningful unit. And with an eye towards supporting action, we consider the geographic unit at which action can be taken, or where governing structures exist with the authority to make sustainable change. Another consideration is the extent to which leading indicators can and should be disaggregated by marginalized communities and population groups, and how refined and consistent the indicators should be in slicing and dicing across. We've long recognized that county-level data mask health disparities, and we continue to seek ways to use the best available information to reveal meaningful health gaps. And we've come to appreciate that as our population becomes more diverse and data collection attempts to keep up with the demographic and social shifts, we've been sitting with questions about how to best generate stable estimates, but particularly for population subgroups that may be nothing alike. So, for example, the category of Asian American can represent Japanese Americans and Indian Americans, which are culturally very dissimilar, and can have implications then for how we conceptualize health. There are also real number issues. For example, providing data for rural counties with smaller populations has always been a challenge. This is also true for population subgroups with small numbers of people. And the more you drill down, tough statistical and ethical questions can emerge. Practically speaking, in our efforts to improve the availability of reliable data for rural and smaller population groups, we also need to be able to meet the suppression criteria of data stewards. And regarding data sources, we heard about some of this in the panel just before lunch, but the way that we conceive of data sources in the next decade is bound to change dramatically. And as we look to this future, it will always be true that data sources have underlying sampling and collection protocols and nuances and definitions of measures. So as we work across these data sources, even when looking at a similar measure, the data can sometimes paint a very different picture. And when we think about end users of the data, we've worked to align what we currently have in terms of data platforms with a focus on relatable geographies. As I mentioned, coordinating with America's Health Rankings and City Health Dashboard and others, we've tried to explore opportunities for linking to local data sources as well that can help with local change makers painting a more nuanced and refined picture. And lastly, I would just offer that at County Health Rankings, we are relatively early on in our journey to support local change makers with an equity lens. And I'm really thrilled to see the critical shift that Healthy People 2030 is taking in addressing equity with an emphasis on historical and current structural drivers. I know you're going to be hearing from colleagues on the topic of equity metrics shortly, and maybe even how we might measure some of those challenging upstream drivers. So I'll just briefly offer a few examples of challenging questions that remain in front of us that may be relevant as we are learning to draw connections between some of those drivers and the downstream health inequities. So far, what it seems is that while the math may be complex, so too is uncovering the normative judgments and values. Regarding measurement of equity, we've been exploring how normative judgments and values implicit in selected indicators can be made more explicit and transparent. And by that, I mean really checking our assumptions and critically examining our approach to the measurement of health disparities. I mean, the current accepted standard approach is to measure health disparities as a way of engaging in conversation about health equity. And while it might be assumed that calculating, comparative differences between subgroups of measures of health to provide objective data that can then be interpreted using normative judgments about whether a particular distribution is fair or just or socially acceptable. In fact, we are coming to appreciate that normative judgment plays a role in the measurement process itself. For example, setting standards, measuring health disparities as a difference from a population mean that implicitly values equality, in contrast to measuring health disparities as a difference from the best observed rate that implies we care about health disparities, but also a preference for reducing disparities by raising the level of health among those who are least healthy. So for county health rankings and roadmaps, this is truly an area of particular relevance as we consider how to be transparent about our own values, but also to support local change makers and bringing a data-informed approach to what we are finding is often difficult conversations about what are core values at play in advancing equity. And really, finally, what is progress? I think how we will define and measure progress for the health of the nation is also a place where it is clear that normative judgments will be at play. One simple example is measuring progress using relative or absolute measures of disparity, such as trends in rate ratios or rate differences. This was articulated in one of the Healthy People 2030 briefs by the Health Equity Subcommittee. And while we recognize that both relative and absolute measures of disparity need to be tracked over time, we also see for ourselves that it's important to be explicit about why sometimes one approach may be chosen over another, and to support local data fluency in that same vein, especially when those two approaches may have different interpretations of outcomes. And as we continue to work towards improving how we measure our progress on health equity, we're really, at County Health Rankings and Roadmaps, aiming to be more explicit and transparent about the normative judgments and values in our measurement decisions, because we truly believe that in being more transparent, we can also prevent some of the criticisms that we know have emerged on selective reporting bias, on statistics that document health disparities and their patterns across the nation. So I believe I went over my time. I apologize, but thank you.